Thank you. Thank you, Jermaine. Thank you, Bob. I am ever so pleased to be here and share a little piece of myself with all of you. God has been good to me in my life, and I trust him with every aspect of it. In 1984, I was diagnosed with epilepsy. I had had what we called back then petit mal seizures. Now we would refer to them as partial complex seizures. And I'd had them pretty much all my life, but they had never been diagnosed. And when I was in my mid-20s, the seizures began to evolve and escalate until they became a little bit more debilitating. At that time, I was run through a bunch of different tests, and it turned out to be the EEG, which was conclusive in diagnosing epilepsy. So the seizures were epileptic seizures. I was started on phenobarbital and Dilantin, which were the drugs of choice at that time, in 1985. And so after a little while, the seizures came under control. I woke one morning with a very strange sensation, thinking something is wrong. I just don't feel normal. Something is very off. And I got up and I went about my day. I had small children and I did daycare in the home, and I couldn't stop. And then I thought, wait a minute, it's not something wrong, it's something right. I don't hurt. My head does not hurt. I had had daily and more seizures my entire life and was in a perpetual state of status post-epileptic. So a post-ictal phase. And one of the symptoms of that post-ictal phase would be a headache. I was 25 years old. The first time in my life I knew what it felt like to not have a headache. So I thought I could get used to this. This is nice. Well, things went along. Things were going well in my life. God was good to me. Then I had one of my daycare children. His parents were in the military, reservists, and they had gone out of the country, and they had their little child with them. When they came back and they brought Giardia with them. A lovely intestinal infection. I did everything that I could at the time. I did the hand washing. I was very vigilant. But this little boy still managed to pass the Giardia to me. And I ended up with giardiasis, just a lovely little case of diarrhea. Went to the doctor. They did a culture. And I got a call when the culture was in from an on-call physician. And he said, you do have giardia, giardiasis, and we're going to treat it. It's a very simple treatment. You're going to take some Flagyl. And I said, that's fine, doctor, just as long as whatever you prescribe will not be a problem with the medications I'm taking for my epilepsy, for control of seizures. And he said, no problem, this is a very benign medication. Well, I took my first Flagyl, metronidazole. And about an hour to 2 hours later, I woke up on the kitchen floor with all the children around me crying. And I called the doctor after I had collected myself. I said, I think I may have had a grand mal seizure. I've got bruises. I just woke up on the floor. I don't know what happened. And they said, should I stop taking this Flagyl? They said, absolutely not. The reason you had the seizure is probably because of the diarrhea flushing your seizure control meds out of your system, so your levels are low. You need to get that diarrhea under control or you'll have more seizures. I took my second dose that evening before bed, and I had my second grand mal seizure, and then a third, and then a fourth, and then I went into what was called status epilepticus. It took almost 10 hours for the seizures to be brought under control. In that time, I coded twice. The Lord was truly with me because I had no fear. I had no fear. And during the first code, I said to the Lord, Lord, if you want me, I am ready. He said, I have much more for you to do. And he sent me back. But I had a little time to rest before I came back. I was in a coma. During the time I was in the coma, I had awake and asleep times, just like we have when we're not in a coma. When I was awake, I could hear and understand what was happening around me. But I was locked in. I couldn't respond. I couldn't tell anyone, I'm here. There were some really good nurses. And there were some not so good. I remember one occasion when a nurse called out from my room, apparently trying to get someone else to come in. Would somebody come in here and help me move this thing? I wanted to cry out, I am not a thing. I am a person. I have dignity. That was a defining moment in my life. While I was in a coma, I made a major life decision. I decided to become a nurse. And I decided that I was not going to be just any nurse. I was going to be a good nurse. I was going to recognize the dignity of every single human being, regardless of their state, stage, or condition in life. Because each and every one of us is created in the image and likeness of God. And if for no other reason, our lives have value. Again, I said I heard things while I was in the coma. One day, I heard multiple footsteps coming into my room. And I didn't know who it was, but then I heard a male voice. And I think it must have been a doctor who was taking some residents on rounds or something. But he said, this one is a sad case. Young woman, 2 small children at home. Her husband is being completely unreasonable. She's essentially brain dead. And there are so many people who could benefit from her organs. But he won't see reason. I said, oh, thank you, honey. I said, you can't have my organs. I need my organs. But I couldn't say it. I couldn't speak it. I was still locked in. Well, that really cemented my decision that I needed to go into healthcare. I needed to be a nurse. I had a lot more moments during the coma, a lot more experiences that I recall. And I won't go into all of it with you. What I will share with you is this. I remember when I was extubated so that I could breathe on my own, and the nurse there encouraging me ever so strongly, breathe, breathe. Come on, just take a breath. And that first conscious breath in my unconscious body was almost painful. But I could breathe, and I started to breathe on my own. And then one day I heard the nurse came in, and I could see her. I had opened my eyes for the first time in several weeks. And she looked down at me and she said, "Well, hello there." "Oh, welcome back." I wanted to say, "I've been here all along." Well, I have, to this day, a great desire to live. I know that when the Lord wants to take me, when it is my time, I will gladly go, because I trust him. But I'm here for as long as he wants me to be here. And that's as it should be. It shouldn't be our decision. It shouldn't be a doctor's decision. It shouldn't be any individual creature's decision. It should be the creator of the creature's decision as to when life ends. God is very, very good. When I came around and I was conscious, I was still paralyzed. All I could do was blink. So my communication was 1 blink for yes, 2 for no. And they realized from that I really was present. I really understood what was going on. I was lucid, but I was unable to speak. I was unable to swallow. I was unable to control my bodily functions. I was completely dependent. I was breathing on my own, though, which, let me tell you, no brain-dead person can breathe on their own. If you are truly brain-dead, you cannot even respirate. So the Terry Shivos of the world are not brain-dead, as our media would like to imply. They are injured in their brains. They are damaged, they are impaired, but they are not dead. And there is no way for any of us to know what they think or feel or desire. Before all of this happened, had anyone asked me, would you want to live in a persistent vegetative state? I would have said, no. Does anybody want to live in a vegetative state? But once I was in that condition, given the alternative, yes, I want to live. So yes, keep my feedings coming, keep my hydration coming. Do not stop keeping me alive. When a person dies, because nutrition and hydration has been discontinued, they're not dying of their disease condition. They're dying of dehydration and starvation. We're imposing a death sentence on someone when we deny them basic human care, basic care. Even if it's medically assisted, nutrition and hydration are not extraordinary care. The ventilator, yes, that's extraordinary care, because you cannot even live for one moment, for a couple minutes. But a death that's going to take days and days and weeks maybe, because of something being deprived, a basic need being deprived, that's not the disease condition that kills that person. So, what happens? Once you think a little bit, we don't have time. It would be a whole nother symposium to go into what is brain death. But I want each of you to stop and think what it is and how in our society today and in our medical community, we really don't have a concrete standard for defining and diagnosing brain death. I was diagnosed as brain dead. I am the very first brain dead person to graduate from my master's program with honors. So, another thing is organ and tissue donation, okay? I had always meant to put that little dot on my license to tell them I would be an organ donor, but I didn't really, I don't know, there was something that held me back, and I just thought, well, I can make that decision later. And I didn't do it. Well, thank God I didn't do that, because they were very anxious to get my organs, you know? And I wonder, how does it happen that a person's decision to elect to be an organ or tissue donor, does that affect the medical decisions, the plan of care? It's something to think about. If you have a little pink dot on your driver's license, I recommend you go home and scrape it off. I stand here today because the doctors were wrong. They were dead wrong. So, a few key things that I want you to remember from this. I want you to remember that every person, you, your spouse, your children, your parents, your neighbor, the homeless man, every single one of us has great dignity. Great innate dignity. So treat yourself with that dignity, and treat your neighbor and your loved ones with that dignity. Another thing I want you to remember is that be careful when you are deciding what you want to do as far as in extreme circumstances. What is ordinary versus what is extraordinary care. And be careful about designating to be an organ donor. Any questions? Yes?
I'd like to know how often they did brain scans on you while you were unconscious, and what did they show?
I know they had an EEG hooked up on me, and there was a period of time where I had... Oh, she's asking how often they did brain scans on me and what tests they had done to try to determine brain death. And I really don't know about brain scan. They may have done it when I was in an asleep state. I do know that they had an EEG, and at some point in time there was a lack of activity on the EEG. However, bear in mind, the drugs that they had to give me to get the seizures to stop are drugs that depress the brain waves. So I was in a medically induced coma. And, I tried to give people the benefit of the doubt and think the doctor just didn't know. But did the doctor not know? I mean, he had to know that I was in an induced coma, and he's telling my husband I'm as good as brain dead because he wants my organs.
What year was that?
1985. Yes.
Did you ever confront that physician?
Did I ever confront that physician? No. Once I came out of the coma, he was nowhere to be found. Never saw or heard from him again. Yes, ma'am.
Was it ever determined whether the flagell was the responsibility of why you went to status?
Good question. Was it ever determined that the flagell was the culprit? Yes, the flagell was the culprit. It is contraindicated for persons with central nervous system disorders. Epilepsy happens to be a central nervous system disorder. Yes,
Do you speak to physicians or medical groups at all about this?
I have. She wanted to know if I've spoken to physician or medical groups, and I have on occasion, yes. Ma'am?
Yes, two questions. One is my father, we had come to the conclusion that he was terminally ill with pulmonary fibrosis. What bothered me is how, something you mentioned earlier, how they cut off, despite our agreement with family, they cut off all fluids and overdosed him with pain medicine, with morphine sulfate IV. And they denied him IV or any,
Yes.
even a minimal amount just to keep him sufficiently hydrated. Not that he was going to save life, we knew he was.
Yes,
terminal.
it's a
And
sad
I've seen
situation.
that 3, 4, 5 times in just personal, and I'm a nurse, but honestly, beyond
Is there-
nursing, I've seen that too many times. And I'm really bothered what we're doing to gain the attention that killing somebody with dehydration.
Exactly.
And knocking them out so they don't know what they're doing.
She's talking about her own personal loved one who, her father, who had, was it pulmonary fibrosis, you said? Pulmonary fibrosis, and he was suffering a great deal, and they ended up withdrawing all fluids and increasing pain medications. The thing is, doing that is very common these days, and what is our role here? As Bob was saying, we are to do no harm. Do no harm. Accelerating someone's dying is doing harm. I'm sorry, I believe it's time for our next speaker to come up. Thank you ever so much. If those of you who wish, perhaps we can touch bases later on. God bless you all. Thank you.
Is it going to work? Is it working? Okay. Is it working now? Yeah, I can hear it now. Well, I'm delighted again. I'm going to be introducing, I'm very honored to be introducing Dr. Christopher Kaczor. Dr. Kaczor is presently a professor of philosophy at Loyola Marymount University here in Los Angeles. He received his PhD from the University of Notre Dame, and then he did postdoctoral work in Germany at the University of Cologne. He's done extensive research on issues of ethics, philosophy, religion, and has had articles published in the Wall Street Journal, the Huffington Post, and National Review. He has been featured on NPR, BBC, EWTN, ABC, NBC, Fox, CBS, MSNBC, and The Today Show. He is the author of 9 books, some of which can be viewed at his information table. Today, he's going to be giving us ethical guidelines for decisions that we or our loved ones might be facing one day. Please welcome Dr. Christopher Kaczor.
Thank you very much for that kind introduction. It's wonderful to be with you today and to talk to you about this extremely important topic. There, is that better? Okay. I was saying that I'm very happy to be here because I think the topic of the symposium today, the conference, is so very vital. Right now, in many states, there's legislation that's being introduced to legalize physician-assisted suicide and euthanasia, and I expect over the next decade or so, these pushes will become stronger and stronger. So having you be here and be informed is very inspiring to me, because we're all going to need to work together in order to make this country safe and just for all people. So today what I'm going to talk about is a number of the ethical questions that arise from euthanasia, and I'm going to consider them really from a philosophical perspective. So let me start off, as a good philosopher would, with a definition. Euthanasia is understood as an action or omission which of itself by intention causes death, in order that all suffering may be in this way eliminated. So euthanasia is defined in terms of not doing an action or not doing an action. That's not really relevant, but it's defined by the intention to cause death, either by doing something like, say, lethal injection, or by not doing something. For instance, not providing food and water for someone, or not allowing them to breathe or something, right? Those would be omissions as opposed to actions. Now, euthanasia is driven by a certain view about the value of human life, and we can really distinguish between three different fundamental views of human life. One I'll call vitalism. And vitalism is the view that human life is the very most important good that there is, and that everything always needs to be done to extend human life as far as possible. On the other extreme, I'll call the quality of life view. And the quality of life view holds that human life only has value in some circumstances. So if you judge that your suffering is outweighing your pleasures, if your pains are outweighing your pleasures, well, then your life is no longer worth living. And in situations like that, either a person can voluntarily choose, or others can choose for them to end their life. And then the middle between these two views is what I'll call the sanctity of life view. And that's the view that human life always has value, but that human life is something that does not always need to be prolonged and extended using every means possible. Now, there are some problems with the first view I talked about, the vitalistic view. And the problem, at least from a Christian perspective, is that it's idolatrous. That is to say, the idea that human life is the most important good of all and everything ought to be ordered to promoting and extending human life as much as possible fails to recognize that, at least from a Christian perspective, the greatest good of all is God. God is the greatest good. And human life is, and so we do not have an obligation to extend and prolong human life as much as possible. One example of this in my own life was of my grandfather. So they knew that he had cancer, and they brought him in to do an operation. They thought he had cancer just a part of his liver, and so they were going to remove part of his liver, and hopefully he'd be fine. So they bring him in there, and they open him up, and they discovered that he had cancer all over the place. It was just completely throughout his body. So they didn't do the surgery. They closed him up and said, okay, well, we can't, we could do the surgery and maybe extend his life by a few days or something, but it's not really worthwhile to perform this surgery for this patient at this time. And then he ended up dying within, I think, 2 weeks. So the vitalistic view, in other words, would be we always need to extend human life as much as possible, and there would be, in this perspective, no such thing as extraordinary means. In other words, we always need to do everything and, prolong the dying process, in other words. Now, the more problematic view, the vitalistic view is held by very, very few people, but the more problematic view is the quality of life view. And on this view, what the quality of life folks want to do is draw a distinction in the human family between those people whose lives are worth living, on the one hand, and those people whose lives are really not worth living, on the other hand. And basically they say, well, of course these people have a right to live, and of course we can't intentionally kill these people. But these other sorts of human beings, well, either they're not really persons, right? They don't really count fully. They're merely human organisms, or they're brain dead, or they're vegetables, that sort of idea. And so for these people, we certainly can intentionally end their lives, intentionally kill them. Now, this sort of division is quite arbitrary, and you see this in euthanasia legislation often, or physician-assisted suicide legislation. The crafters of the legislation often say, well, physician-assisted suicide is only for some cases, and they'll say, well, if you've got 6 months to live, well then we'll allow physician-assisted suicide. But these sorts of divisions are entirely arbitrary. I mean, why, in other words, should it only be allowed for people with 6 months to live, and if you've got 8 months to live, well, suddenly it's not allowed at all. It doesn't really make sense. It's just sort of an arbitrary line drawn in the sand. The other problem is that our fundamental rights do not go away just because we're unconscious, either permanently unconscious or temporarily unconscious. And I think almost everyone can come to recognize that this is true. So imagine the famous actress Jennifer Aniston. She's on set filming, her latest movie. And after the shooting is done, she goes off stage and she slips, hits her head really hard, and is knocked unconscious. Right? So they rush her to the hospital, and they have her in the ICU, and they're not sure whether she's going to make it, and they're not sure whether she's permanently unconscious or whether she's going to recover and be conscious again. So that night, a very evil janitor sneaks into her room and has sex with her. So she gets raped. Now, everyone that I've ever talked to about this case says, of course, that was completely wrong. And of course, the wrongness of the janitor's act does not depend in any way on whether she's going to recover her consciousness later or whether she's permanently unconscious. But if that's true, which everyone grants, well, then it turns out that our fundamental rights and dignity do not go away when we're temporarily unconscious or when we're permanently unconscious. In other words, being temporarily or permanently unconscious is completely irrelevant to our basic rights and dignity. I mean, no one would hold, well, we can't tell whether the janitor's action was wrong or right until we figure out the proper diagnosis for Jennifer Aniston. And if it turns out that she's permanently unconscious, well, then what he did wasn't really wrong. I mean, no one holds that. That's a crazy view. So the bottom line is this. I think this case shows us very powerfully that our basic dignity and our basic human rights are not something that goes and comes away and hinges on whether we're able to be conscious in the future or whether we're conscious now. That's completely irrelevant for our basic rights. This is a point that has been touched on before, but from the sanctity of life view, all human beings have this intrinsic worth. And what intrinsic worth means is that human beings have this worth in all conditions, in all circumstances. So the worth that we have as human beings is not contingent or dependent on whether or not we're suffering or whether or not we're in pain. It's not as if we have value and if we suffer, all of a sudden our value, goes away or falls off. So the view that I'm proposing is that all human beings should be accorded basic human rights. All human beings. And if we say all human beings, what we mean by that is every single member of the human species, from the very beginning of life all the way through to the very end, regardless of any sort of condition. So this is what I'll call the inclusive view. And the inclusive view says if you're human, well, then you deserve to be respected, you deserve to be protected, and your basic rights, like your right not to be intentionally killed, should always be protected by law. The other view, of course, is the exclusive view. And that's the view that wants to divide the human family into these two camps, right? Where you say, well, of course, if you're healthy and conscious, then you have basic rights. But if you're disabled or if you're unconscious or if you're quote-unquote brain dead, persistent vegetative state, well, then it would be okay for someone to say to kill you. If you look back at history, every single time we've divided the human family into these two camps, we've made a horrible decision. Right? When we said, well, if you're white, you have basic rights. If you're a person of color, you really don't. If you're a man, you have basic rights. If you're a woman, you really don't. If you're European, you have basic rights. If you're a native person, you don't. Every time we've done this, we've made a catastrophic mistake. So I think that history teaches us that we ought to be inclusive, that we ought to learn from the terrible mistakes and errors of history, and we ought to therefore respect and protect every single human being, including those at the end of life. So the second thing I want to talk about today is this question. Is there an important moral difference between so-called active euthanasia, that is intending the death of the patient by some act, like lethal injection, and passive euthanasia, that is intending the death of the patient by some omission, like taking away all food and water? Is there a difference? Now, some people say there is. And they say, well, yes, of course, maybe active euthanasia is wrong, but passive euthanasia, just not feeding someone, well, that can be fine. I think this is mistaken, in part because the distinction between omitting an action and doing an action is not morally relevant in terms of distinguishing good and evil actions. So let me give you an example that I think will clarify this for you. There's a man who wants to get an inheritance. And the way he's going to get the inheritance is to kill his young nephew. So the young nephew's in there taking a bath, and the evil uncle walks in there, grabs the nephew, holds him under the water, and drowns him. Right? Everybody would say, well, of course that's wrong. Right? That's murder. So it's an action intended to cause death. Case number 2, exact same. They have the nephew, and the uncle can get the inheritance if the nephew dies. He walks in the bathroom planning on murdering him, and he notices the nephew just happened to slip in the bathtub and is knocked out underwater and is drowning. So the uncle sits there and, pulls up, gets out a magazine, starts reading, and just sits there while the nephew dies. Well, everybody would recognize, of course, the uncle is doing something wrong. We wouldn't say, wow, it's perfectly fine what he did. He didn't do an action, so, no problem. The fact is, he did an intentional omission for the sake of killing his nephew. And that's also evil. That's also wrong. That's also bad. So the difference between murder and not murder is not action on the one hand versus omission on the other, right? Of course it's wrong for a mother of a baby to throw the baby and, kill the baby in that way. But it's also wrong for the parents to omit to feed the baby and have the baby die in that way. That's also wrong. That's also murder. Why? Well, because they're murdering by means of omission. They're intentionally not feeding the child. Now, there could be, in very unusual circumstances, cases where parents are, physically detained and they can't feed their child. Okay, well, that's not their choice to not feed the child. But if they choose voluntarily to not feed the baby, that's murder, right? Not murder by action or commission, but murder by omission. And that is also wrong. Third question, is it always wrong to, quote, let someone die? Here I think we have to distinguish between intention and foresight. So an intended consequence is a consequence that you're choosing deliberately to bring about. A foreseen consequence is something that you're not choosing deliberately to bring about, but you're accepting it as a side effect. So for instance, if you go exercise, presumably what you're intending is to facilitate your bodily health, to get in shape, to lose weight, etc. Presumably you are not intending when you exercise to wear down your running shoes, right? The point of exercising isn't to make sure that your running shoes are worn down. Or if you drive a car, the intention is to get to the place you're going. The unfortunate side effect would be that the car emits, noxious gases or something, or that the gas in your car goes down. You're not intending to run out the fuel tank. That's not your goal. That's not the intention. It's an unfortunate side effect of what you're doing. So ethically speaking, we can ethically foresee some bad side effect and not prevent it. That's not always wrong. So the classic example of this is the invasion of Normandy on D-Day. So the Allied generals know for a fact that some of the brave soldiers who storm the beaches, some of them will die. But they are not intending or choosing to kill the troops. They're accepting as an unfortunate side effect of liberating Europe and saving civilization from Hitler. They're accepting as an unfortunate side effect of that good goal that some people will die as a side effect. So another example would be between the good dentist and the bad dentist. So a good dentist may do dental work on you, foreseeing as a side effect that this is going to cause some discomfort. But that's not the dentist's goal, right? He's not setting out to harm you or cause you pain. On the other hand, the sadistic dentist, the bad dentist, right? Okay, well, that would be somebody who delights in causing pain, right? Who's like, well, I'm going to give just a little, not quite enough Novocaine here, and I can't wait to watch this person, in pain. Okay, well, that's a totally different thing. Why? Well, it's different because the sadistic dentist is intending to cause pain. And that's very different than the good dentist who foresees, that this may cause some pain. It's not what he's trying to do. It's a side effect of trying to help your dental health. So this leads us to the next distinction, and that's between ordinary and extraordinary means of preserving life. So what is this distinction? Well, ordinary care, in ordinary care, the benefits of providing care compensate for the burdens of care. And in extraordinary care, the benefits of care do not compensate for the burdens of care. So let me be very clear here. We are not comparing the benefits and burdens of the patient. We are not comparing the benefits and burdens of the patient's life. The patient's life is not at issue. What's at issue is whether this treatment is burdensome or beneficial. And some treatments can be more burdensome than beneficial, right? So imagine a case, I have actually my grandmother-in-law is 95 years old, right? So let's say she's having some difficulties with, heart trouble or something. Now, should she receive a heart transplant at 95? Well, presumably that would be extraordinary care. Why? Well, not because her life isn't worth living or she doesn't count or she's not really a person. No, she's just as much a person as I am or anybody else. She's fully a person. But in this case, when you're 95, the burdens of getting a heart transplant are very, very substantial. I'm not an expert in this, but I'm told it takes years to recover, that it's extremely painful, that it's going to be very hard for her physically and psychologically to go through. And so that's a very burdensome treatment. Now, what would be the benefits of her getting a heart transplant at 95? Well, the benefits would be maybe it might extend her life by a little bit, maybe 1 or 2 years, maybe, but probably she's going to receive very, very little benefit. So if you're thinking about the burdens and the benefits of a treatment, for someone like that, she could come to a reasonable judgment that, I'm not going to get a heart transplant at 95, right? I've got other health problems, I've got cancer, so it doesn't make sense, given the burdens and the benefits of the treatment, to get the treatment. That's, again, underline, not saying her life is not worth living, she doesn't really count. No, she's equal to anyone. But in her case, given her advanced age, the benefits are going to be very little. There's no way she's going to live 20 more years. And the burdens are going to be very, very significant because it's very hard to recover from that. And the older you are, the more hard it would be to recover for that, etc. So she can say, I'm not going to receive this treatment. By contrast, ordinary care is care in which the burdens of the treatment are small and the benefits of the treatment correspond to that. So obviously, providing food and water. Now, there could be rare cases in which there is not an obligation to provide food and water. I'm thinking here of cases when someone is so sick that they can't assimilate the nutrition anymore. So say someone with stomach cancer or something, where if you put food in their stomach, it's not even going to work properly. Their stomach's all messed up. Okay, that's a horrible case, but in some cases, people are so ill that they can't assimilate the nutrition. Okay, well, in that very rare case, there's no obligation to provide, say, food and water because they can't make use of it. Their bodies are so diseased that they can't assimilate it. But in a normal case, where someone's a normal human being, of course it's part of ordinary care. We all need this, not just sick people. Everyone needs food, water, shelter in order to be able to live. So that would count as ordinary care. The final question I want to address is this. How do we respond to someone's request, will you help me die? Will you help me die? And this applies obviously to people in the healthcare professions, but it can even apply to people, in regular life. I mean, you may encounter friends or family members who are at the end of life and really having trouble, and they just feel that they say, will you help me die? Well, this question was addressed, I think, in a very interesting way by a Columbia University professor of psychiatry named Philip Muskin. And in the Journal of the American Medical Association, he, as a psychiatrist, teases out the different meanings that this question can have. So, will you help me die can mean, what can I do? People at the end of life sometimes feel as if they've lost control of everything. And their question can be, what exactly can I do in this situation to, how should I handle this end of life? Another question he says sometimes people mean when they say, will you help me die, is, am I getting punished? Some people really think that God is directly punishing them for their own personal sins. And they have a kind of theology where they think, if anything bad happens to me, this is God directly intervening and punishing me for my own sins. Now, sometimes it is true, right? Sometimes people do bad things and they do get punished, right? For instance, when people are very selfish and unfriendly towards others, well, they end up not having any friends, right? And that is a kind of punishment that is inflicted, as it were, because of their bad behavior, or they drink way too much and they have a terrible hangover. But I think it's a huge theological error to think that all suffering is a direct result of one's personal sin. And the reason I think this is true is because, theologically speaking, we know that our Lord and Our Lady were innocent of sin. And yet, isn't it true that Jesus suffered very grievously? Obviously, physically, in terms of the cross, but even emotionally, right? Think of the Garden of Gethsemane, one of the shortest verses in Scripture, right? Jesus wept, right? So clearly, Jesus suffered. We know also that Our Lady suffered. So this is important, because when other people are suffering, sometimes they can think, this means God hates me. And that's important to help people realize, no, it doesn't. God didn't hate Jesus. God didn't hate Mary. And if you're suffering, that does not mean God hates you. It doesn't mean God hates you at all. Another question is this: am I loved and wanted? Will you help me die is a way of people asking of other people, do you still love me? Am I still valuable to you? Or do I not really count anymore to you? And again, I think that people of goodwill should respond, of course we love you. Of course you're wanted. You're important. You're a human being. You're my brother. You're my sister. You're my dad. You're my mother. You are important. Another question that will you help me die can sometimes mean is, who am I? Sometimes people at the end of life develop a kind of split, and they want to split between themselves and their body, or the real me and the sick me, right? They have a kind of identity crisis. And again, it seems to me the answer for this identity crisis is not to kill them or help them to die, but to help them work through this very challenging issue. There's a reason that in the Catholic Church we have a sacrament called anointing of the sick. Because when you're very sick, when you're dying, this is a hard time. This is a very challenging time. And we need God's help. And whether or not we're Catholic, we can always help people that are at the end of their life. And we help them not by taking away something that's good that they have, their life, but by helping them with their psychological issues, their emotional issues, their physical issues, standing beside them and accompanying them, and being compassionate and kind. Will you help me die, says Philip Muskin, can also mean, can I be forgiven? That's a question many people confront at the end of their lives. Can I be forgiven? I think an honest person recognizes that they haven't been everything they could have been, that they didn't always pursue God's highest and best. And so people need, I think, at the end of life to feel God's mercy, to feel God's forgiveness. And again, killing them is not a way of making them feel God's mercy and forgiveness, but they need that compassion. Will you help me die, says Philip Muskin, can also mean, is there hope? And here's a place where people of faith can provide a wonderful witness and a wonderful comfort to people in death. At the end of life, from a Christian perspective at least, there is hope. There is hope. Even if life has not gone well up to that point, there's always hope. A beautiful story told by Archbishop Fulton Sheen was of a terrible man. He was an atheist and tried throughout his life to cause people to leave the faith. He was an alcoholic and divorced his wife and a horrible father. He was just a terrible guy. And his family, though, was Catholic, and so they encouraged priests to come see him. And the priest would walk in and he said, "Get out, I don't want to see you." And so finally they called Archbishop Sheen and they asked him to come. Last resort Sheen. So he shows up there, and the guy says, "Get out." So that was the first time that he showed up. But Fulton Sheen came for the next 39 nights, so 40 nights in a row. And each day he'd stay a little bit longer, 10 seconds, 20 seconds. So by the end he got up and he was staying for, a little bit of time. And then the last night he said, "Get out." And Fulton Sheen said, "Well, do you want me to leave? I've got someone else with me, the good Lord. I brought the Blessed Sacrament. Do you want him to leave too?" And he said, "Yes, get out of here." So Fulton Sheen said, "All right." He said, "Well, listen, I'm going to leave, but I want you to know that if you want me to come back, I will." And he said, "I don't want you to come back." And he said, "Well, look, if you feel you want to turn to the Lord at the last moment, just say, 'My Jesus, mercy.' Get out of here. I'm not going to do that. Leave." So Fulton Sheen left, right? And then that night, he got a call from the hospital saying that the man died. And Sheen said, "Well, did anything happen at the end?" He said, "Yeah, as soon as you left, he started saying, 'My Jesus, mercy.'" And he kept saying, "My Jesus, mercy," until he died. So even for someone like that, until the very last moment, seemingly rejecting God, there's hope even for someone like that. So we have a very important role to play. Each of us plays a different role. God calls us personally to play a role that we can play in this great struggle for life, in this great struggle for mercy for all people, in this great struggle to protect and respect every single human being. Thank you very much. So I'll be happy to take some questions. Yes?
Could you tell me if this is the proper place to put this, where does the current phrase best practices fit into all of this? Because my understanding is that if you have 100 people that are sick, and this would then, they figure out through data and surveys that 80% of those people would get help, but 20 won't. Where does that fit into your list?
Okay, the question was, where do best practices fit into the list that I've given? And the answer is actually, I'm not exactly sure where that would fit in, because I'm not exactly sure what best practices means. But maybe one way to think about it would be like this, that when we talk about the distinction between ordinary and obligatory care on the one hand, and extraordinary, that is non-obligatory care on the other hand, that I would say that partially this is something that is personal. That is to say, this is something that there is not a one-size-fits-all answer. So what do I mean by that? Well, you can imagine situations, and this is something actually that was dealt with by theologians in the 19th century. So their case was this. Imagine somebody who lives in Ireland and is told by doctors, if you're going to be cured, you have to get in a different sort of climate. And so you're going to have to move to, I don't know, the middle of Africa or something in order to restore your health. Otherwise, if you stay in Ireland, you're going to die. So imagine the guy is, a grandfather. He's been in Ireland his whole life. His whole family's there. Does he have an obligation to move to Africa to be in this tropical climate so that he can survive? And their answer was no, right? That you don't need to do everything possible, everything that's, physically possible for you in order to survive. So, but you could imagine another person in Ireland saying, well, yeah, I guess I'm gonna have to move to Africa then. I really want to stay alive, and so I'm gonna move to Africa. Now, does everyone have to do that? I think the answer is no. So you could have people that are in similar medical circumstances that nevertheless choose different medical treatments in order to, for themselves. And it seems to me that's perfectly legitimate. I don't think we need to have a one-size-fits-all that everyone does exactly this or that. Now, everyone, of course, should respect human life, and no one, therefore, should intentionally kill a human being. So we can say that. But outside of intentional killing, what we should do is a matter governed by practical wisdom, by the virtue of prudence. And prudence is something that is relative to the people, to the individual, in the sense of what's prudent for me to do in a certain situation may or may not be exactly the same as what's prudent for you to do in a certain situation, right? Because I'm married to my wife and I've got my kids, and my situation may be different than your situation, right? So maybe, you should have a big Thanksgiving dinner and invite 40 people, and maybe I shouldn't, or vice versa, right? We can't, in terms of what we should do, there's not, other than we should love God and we should love neighbor, what exactly we should do is a matter of practical wisdom. Within the parameters of, there are certain things we should never do, like murder, like suicide, etc. But within those parameters, what exactly we should do is not something that's a one-size-fits-all. So best practices, another way to put this would be, it seems to me that best practices might be a kind of a rough and ready guide, but I don't think it can be a guide for every single person in every single situation that they have to do whatever the quote-unquote best practices is. Yes, sir.
You mentioned Phil.
Yeah, Philip Ruskin is his name. It's or Muskin rather, Muskin.
Is there a book or?
Well, it's an article. This was an article in the Journal of the American Medical Association. And I don't have the year for that, but if you just type in Philip Muskin, Columbia Journal of the American Medical Association, the title of the article is "Will You Help Me Die?" and it's something like the various meanings of it, or what people are really getting at, something like that. He's a psychiatrist, yes. Yes.
Can I give you a scenario?
Sure.
A 90 and let's say 11-month-year-old man, totally handicapped, complete care, congestive heart failure, COPD, blind, Alzheimer's. Is it ordinary care or extraordinary care to replace
So the question was, if I understood it right, you had a 95-year-old man? 90-year-old man. He's very ill. He's sick. He's got Alzheimer's, etc. Is it ordinary or extraordinary care to replace the battery in his pacemaker? That's an interesting question. If you had someone who was competent, then it seems to me the answer is easier to answer because you could have the person just say, I don't want this, or I do want this, or whatever. So is a pacemaker itself ordinary or extraordinary care? I don't know. That's a good question. I think it would probably depend on the circumstances. I guess I wouldn't say it's always required, because you can imagine somebody, for instance, let's say you had somebody who was suffering from cancer, and the doctors came to that person and said, you are going to, we think you're going to have probably, 3 months to live with the cancer. You're at the end stages. I think clearly for someone like that, it wouldn't be required to also get a pacemaker put in, because they already are going to die from these other things. I'm not sure, I'm not a doctor, so I don't know how burdensome it is to put in a pacemaker, but I'm guessing it probably is, it's the heart, it's probably pretty complicated and stuff, so. Yeah. That's a good question. I don't know. I'll have to think about that more. I guess I want to say I want to think about it more. Yeah.
My question is, you published different articles and your writings to different diverse media groups. What are some of the major their objections or their main rebuttals against your writings, and what are the most common things that they say against your values and your beliefs, and how do you dispute that or comment that?
The question was, in your writings and stuff, what's the most common objection that's raised, and how would you push back against that? In terms of euthanasia, I think the most common objection raised is, well, this is my body, this is my life, so I should be able to do whatever I want with it, right? This sort of appeal to autonomy. And I guess the way I push back at that is to say, well, of course it's your body, of course it's your life, but it doesn't fall from that therefore you can do anything you want with it, right? I mean, clearly there's thousands of laws governing our bodies, right? We're not allowed to take crack, we're not allowed to walk in certain places, we're not allowed to say certain things in certain places, etc. So somehow the idea that it's your body and therefore, ethically speaking, it's free, anything you want to do is fine, that just doesn't follow. It doesn't follow legally, but it also doesn't follow ethically, because ethically speaking, our various gifts, our bodies, our intelligence, everything that we've been given, are not just ours to do whatever we feel like, but ethically speaking, we should use all of our gifts, including our bodies, as a way of serving God and a way of serving other people. So yes, of course it's your body, but it doesn't fall from that therefore you should be able to do anything you want with it. I think I have time only for one more question, so yes. Oh, sorry.
And single payer coming up even more so. I'm sure the question of the cost-benefit analysis is becoming even more dominant. And I know in single payer in UK that people over 80 will not be allowed to have a cataract extraction. And so I know one woman who was going to 101, and they had to provide nursing care for her, but they wouldn't do the surgery. It was totally fine. So that becomes even more of an ethical issue that is going to be discussed. What's your thoughts on that, and how would you respond to the powers that be that are making these kinds of decisions for each of us individually?
Yeah, so the question, in case you couldn't quite hear, was given the move towards Obamacare and the move towards, among some people, to single-payer system, what will be the ethical ramifications of all that? Well, I think that you're right to note that there could be very serious and very detrimental ethical implications for that. I mean, you could have situations where some committee somewhere is deciding, who lives and who dies and who gets cataract surgery and who doesn't. And for me, at least, I think that's a problematic sort of scenario. I think in general, the principle of subsidiarity ought to be recognized, and that is that those most closely connected with the situation understand the situation best, And so in general, they're the ones who should be making the decisions. And the more federalized healthcare gets, I would think it's almost inevitable that these decisions will be farmed out to Timbuktu, Washington, D.C., who knows where. And I think that could be very dangerous. So thank you very much.